So in this video, we will study about condylar sagging. The contents will be introduction, definition, incidence of condylar sag, risk factors, condylar sag and IVRO, the types, intraoperative diagnosis, prevention of condylar sag, in case of IVRO, BSSO, Leafort 1 osteotomy, few articles at a glance and conclusion. So, malocclusion after orthognathic surgeries like BSSO, IVRO, Leafort 1 osteotomy, the malocclusion may be the result of failure of rigid fixation at the osteotomy site, occlusal shift during fixation, or improper condylar position. So these are the three main factors why we see malocclusion after orthognathic surgeries. So the first reason can be due to a failure in the rigid fixation method at the osteotomy site. There can be shift in the occlusion after fixation, or there can be improper condylar position. So condylar sag is the most challenging to diagnose and treat correctly. The most troublesome sequelae are skeletal instability and anterior-inferior condylar displacement with resultant unpredictability of the post-operative mandibular position. So amongst all the other factors that I've mentioned earlier, like your problem related with the fixation method or the occlusion shift, amongst those factors, the condylar sag is one of the most challenging thing to diagnose and rather treat them correctly. The sequelae following condylar sag are really troublesome. The sequelae can be skeletal instability, there can be anterior-inferior condylar displacement. Okay, so the term condylar sag was coined by Hall et al. In the year 1975. They described the influence of the condylar position on post-operative occlusal stability following the release of IMF. So once we release the intermaxillary fixation in the post-operative period, there is a influence of the condylar position, that is how the condyle has been positioned in the glenoid fossa. That position of the condyle has a very important influence on the post-operative occlusal stability of the patient's mouth. So we can define condylar stability as an either an immediate or a late change. Okay, so it can be seen immediately after a post-operative period, immediately in a post-operative period, or later in a post-operative period. So it can be defined as an immediate or a late change in the condylar position in the glenoid fossa after surgical establishment of a pre-planned occlusion and rigid fixation of the bone fragments, leading to a change in occlusion. So that is the main problem related with condylar sag. So why we should worry if there is a condylar sag in a post-operative patient? Because the occlusion will be deranged in that patient. There can be various complications following orthognathic surgery. Okay, so there are various complications, and amongst those complications, the neural deficit problem with the inferior alveolar nerve, IN nerve, is the most common problem. It is seen in more than 50% cases. Okay, and these terms are like present in this article, the International Journal of Oral and Maxillofacial Surgery 2017. They have mentioned that neural deficit is the most common complication. Okay, and following that, TMJ dysfunction is the second most common complication. It is are present around in 13% of the cases, and this TMJ dysfunction is mainly caused due to condylar sagging. Okay, other complication can be hemorrhage or bleeding seen in uh, intraoperative phase or in the postoperative phase. So now let us look at the various risk factors that are associated with condylar sagging. There can be incorrect vector during condylar positioning. There can be an incomplete or green stick split that prevents condylar seating. There can be muscular ligamentous or periosteal interference. There can be intra-articular hemorrhage or edema and flexing the proximal segment while placing the rigid fixation. So these are the various risk factors that are associated with condylar sagging. Now coming to the types of condylar sagging, it can be either central condylar sagging or peripheral condylar sagging. Now the central condylar sagging can be unilateral, bilateral, peripheral, type 1, type 2. Similarly, your peripheral can be again unilateral, bilateral, okay? So let us look here the types of condylar sag. Central condylar sag occurs when the condyle is positioned inferiorly in the glenoid fossa and makes no contact with any part of the fossa. After removal of the intermaxillary fixation in the absence of intracapsular edema or hemarthrosis, the condyle will move superiorly, causing a malocclusion. Now coming to the peripheral condylar sag. Peripheral condylar sag type 1 and we have peripheral condylar sag type 2. Okay. So the peripheral condylar sag type 1 occurs when the condyle is positioned inferiorly with peripheral contact with the fossa. That is peripheral contact in the sense that there can be lateral, medial, posterior or anterior contact with the fossa while the IMF is in position and the teeth are in occlusion. So the condyle is positioned inferiorly with the peripheral contact with the fossa. Delayed occlusal relapse occurs as a result of condylar resorption. So in case of peripheral condylar sag, we can see delayed occlusal relapse due to condylar resorption or change in shape. Now coming to the peripheral condylar sag type 2, it occurs when the condyle is positioned correctly in the fossa while the IMF is in position and the teeth are in occlusion. However, the incorrect placement of rigid fixation causes flexural stress in the proximal segment. So once the IMF is removed, the tension in the proximal segment is released and the condyle moves either laterally or medially or slides inferiorly. So condylar sag can be of two types. It can be either a central condylar sag or it can be a peripheral condylar sag. So let's see what is a central condylar sag. In case of central condylar sag, what happens is that suppose this is your glenoid fossa and this is your condylar head. Okay, this is your mandible. Suppose this is the condylar head and this is your glenoid fossa. So in this case, what happens? There is a gap between these two, okay? So there is a gap between the glenoid fossa and the condylar head. And the condylar head, condyle is placed caudally with respect to the fossa. And there is no contact between condyle and the fossa. So there is no contact between them and it is present caudally. Caudally means lower, okay? Cephalad means towards head, caudal means towards leg. So this is the central condylar sag. Now coming to peripheral condylar sag. Okay, one thing is left, that central condylar sag can be either bilateral or it can be either unilateral. Okay, so only one condyle may be affected or both the condyles can be affected. Now coming to peripheral condylar sag. Now this peripheral condylar sag are of two types, type 1 and we have type 2. Now in case of type 1 peripheral condylar sag, it is a bit similar to the central condylar sag, but there is a huge difference also at the same time. The difference is that as in central condylar sag, we have seen that there is a gap between the condylar fossa and the condylar head. But in case of type 1 peripheral condylar sag, there is contact, okay? So there is contact between the condylar head and the fossa. Now this contact is usually either present laterally, medially, posteriorly, or anteriorly. Okay, so this contact is present in a laterally fashion, medially, posteriorly, or anteriorly. So there is contact, there is no gap here, but the condyle is present caudally only. Okay, that is lower fashion, but there is a contact but present caudally. That is the difference between a central condylar sag and a type 1 peripheral condylar sag. So when we remove the IMF, so once IMF is removed, there can be malocclusion. Okay, why malocclusion? Due to condylar resorption. And this malocclusion is delayed. In case of type 1 peripheral condylar sag, we see delayed malocclusion. So after removing IMF, immediately postoperative period, we won't see malocclusion because resorption obviously takes time. So after few months, we will see that gradually the patient is having problem of malocclusion. And when we do the CT scan, we will see that the condylar head has started resorbing. And because of this resorption of condylar head, there is malocclusion. Now let us look at the meaning of type 2 condylar peripheral condylar sag. So type 2 peripheral condylar sag is a completely different entity. Here what happens is that there is no gap between condylar head and the fossa. There is no gap between them. The condyle is positioned correctly. Condyle is positioned correctly. But now here is a twist. Now we will remove the IMF. So once we remove the IMF, we will see that there is immediate malocclusion. Okay. So why is this happening? This is happening because of incorrect rigid fixation placement. Incorrect rigid fixation placement. So this is the main difference between a type 1 and a type 2 peripheral condylar sag. In type 1 peripheral condylar sag, we will see a delayed malocclusion. Okay, here we will see a delayed malocclusion. This delayed malocclusion is because of condylar resorption. So there is contact between the condyle and the fossa either laterally, medially, posteriorly or anteriorly in type 1 peripheral condylar sag, and the condyle is positioned caudally. Whereas in type 2 peripheral condylar sag, there is no gap between the condyle and fossa. Apparently, we will see that it's completely normal. There is no problem associated with it. It will look like that, okay? The condyle is positioned correctly. But once we remove the IMF in the post-operative period, immediately after operation, we will see there is malocclusion. So there is immediate malocclusion after removing IMF. And the reason for this is the incorrect rigid fixation placement. The plating was wrong. The placement of the plates, the placement of the fixation was wrong. That is the reason there is derangement of occlusion in the immediate post-operative period. Now let us again revise quickly. In case of central condylar sag, what was happening? The condyle is placed caudally with respect to fossa. There is no contact between the condyle and fossa. It can be either bilateral or it can be unilateral. That's it. Okay. And because of this gap between the condyle and the fossa, once IMF is removed, in case of central condylar sag I'm saying, so once we remove IMF, the mandible will rotate in a clockwise direction posteriorly. So due to the clockwise rotation of the mandible, we will see anterior open bite in case of central condylar sag. In case of bilateral central condylar sag, we will see anterior open bite. Whereas in case of unilateral central condylar sag, we can see posterior open bite. Okay. Now coming to the peripheral condylar sac. Peripheral condylar sac can be either type 1 or type 2. In case of peripheral condylar sac type 1, there is contact between condyle and fossa in the laterally, medially, posteriorly or anterior direction. And once IMF is removed, delayed malocclusion is seen because of the condylar resorption. Whereas in case of type 2 peripheral condylar sag, there is no gap between the condyle and fossa. Condyle is positioned correctly. Once we remove IMF, we will see malocclusion immediately because of incorrect rigid fixation placement.